The objective for this lesson is to review the pH scale, review action of carbon dioxide and bicarb in the body, learn about the Allen's test and how to take an arterial blood sample, how to interpret ABG results, and we're going to discuss the nursing interventions in acid-base imbalance. This video shows you how to draw an ABG and the Allen's test. The Allen's test is done to determine if the hand has additional arterial blood supply in case during the ABG the artery clots or becomes or is being used, so that to ensure that the whole hand has enough blood supply during the test. So that's why you do the Allen's test, and then it shows you all the steps to draw an ABG. On this slide, I'll let you read it, but your CO2 is representing your respiratory system, and it's an acid. When it's dissolved in water, it becomes carbonic acid, and vice versa. When bicarb with hydrogen is dissolved, it also becomes carbonic acid. So that's the buffer system that I'm talking about here on this slide. So when a person's CO2 level rises, so does their carbonic acid levels, and vice versa. It's the carbonic acid, CO2, and bicarb maintain homeostasis, and they do this by the lungs will hold on to or let go of CO2, or your kidneys will excrete hydrogen ions or retain bicarbonate to return the pH to normal. So that's the goal of the body, is to have a normal pH. And what do arterial blood gases assess? They want to assess oxygenation, not only that, but oxygen delivery. So your PaO2, which is your partial pressure of oxygen that's in your blood, it is the normal range is 80 to 100. Your SaO2, which is your oxygen sat that we do during vital signs, the normal is 95 to 100. Your hemoglobin for females is 12 to 8 grams per deciliter, and males it's 14 to 18 grams per deciliter. And then we have cardiac output, which should always be between 4 and 8 liters per minute. So anytime there is something out of range in these numbers, our body is going to compensate. So it can compensate by increasing respiration to increase oxygen, and it can increase the heart rate to increase cardiac output. For COPD patients, they also will increase their red blood cells, which will increase their hemoglobin because they need increased oxygen transport. If your PaO2 is less than 80, you have hypoxemia. For elderly between ages of 60 to 70, your PaO2 will start to decrease until it normally will stay between around 70. So as we age, it's not going to be 80 anymore, it's going to be closer to 70, and that will be their normal. So you're caring for a client with shock, and you're concerned about hypoxemia and respiratory acidosis with your client. What findings should you analyze for evidence of hypoxemia and respiratory acidosis in a client with shock? And it is your arterial blood gas findings. So this is just a review what the pH scale is. It's based on hydrogen ions. The range is 1 to 4. Our blood is slightly alkaline at 7.34 to 7.45. An increase of hydrogen ions is acidosis. So our pH is going to be less than 7.35. And a decrease of hydrogen ions is alkalosis, which our pH is going to be greater than 7.45. 7.45. Death may occur if your pH is less than 6.8 or greater than 7.8. And so I just thought this little meme, it says you're a 10, you're on the pH scale, maybe because you're basic. So just understand that the higher the number, the more basic the result, or base, or alkaline, okay? So maintain homeostasis, that's the goal of our body. We have so many checks and balances, and this is just one. So understand that carbon dioxide and water will dissolve and become carbonic acid, and then it can also turn into hydrogen and bicarb. So they all break down to each other. It's this process, it's the buffering system that will try to keep our pH in the normal limits. That's the goal of our body. So COPD patients, their ABGs are usually within normal limits in the beginning, but as they deteriorate, they are not. And this is an example here. So we have CO2 changes into carbonic acid. So if they have an acidosis, the kidneys will excrete and retain bicarb, so the pH returns to normal. And that's the goal of treatment and the goal of our body. In this page, it's telling us, what does our body do to compensate for said imbalance? So we have respiratory acidosis. What does our body do to compensate? We excrete hydrogen ions and retain bicarb. For respiratory alkalosis, we retain hydrogen ions and excrete bicarb. In metabolic acidosis, we exhale CO2 and water, and in metabolic alkalosis, we retain CO2. Those are the compensatory mechanisms that help our body return back to homeostasis or get our pH within normal range. So this is a video you can watch. It shows you how to interpret ABGs, but if you prefer to do the tic-tac-toe method or whatever works best for you, make sure you practice whatever you are planning to use. I just like this one. And here are our values you need to memorize for our class. Recognize that the pH is 7.35 and to 7.45. This is the normal range. Anything lower than this is acidosis, and anything higher than this is alkalosis. Remember, the higher the number, the more basic or alkalotic it is. So, in CO2 represents the respiratory system, and it's kind of handy that the numbers are 35 to 45. It matches our normal values at the end of the 7.35 and 7.45. So that one's easy to remember. Our metabolic is acidosis is, the metabolic is 22 to 26, and the way the numbers go for this match the pH. So one of the fun things to remember is Rome. So respiratory is opposite of the pH scale, and metabolic is equal. So that spells ROME. So that's a good way to remember it. And then we have our PaO2, which is hypoxemia if it's less than 80. On this page, I have all the steps that are in your notes to interpret ABGs. And I think the best way is to just practice doing them. The one part that trips people up the most is determining the compensation, and I'm going to go through those when I go over the page 3 homework at the end here. So you might want to skip to that if you would like to hear. This triangle is super important to memorize. Anything between 7.35 and 7.4 is considered normal, yet it's an acidosis. And 7.40 to 7.45 is an alkalosis. So anything in this triangle is compensated, yet you have to know the other numbers to know if it's an alkalosis or an acidosis. Even though it's compensated, it's still going to have a disturbance. We tried this in class, and those are all normal. So this is a normal ABG. And the next section that we talked about is how to determine what the causes of the acid-base imbalances and what to do about it. So the next one is respiratory acidosis. You're going to have ABG changes. Your pH will be less than 7.35. Your PaCO2 will be greater than 45. The etiology, and this is circle, star it, write it in big letters, is hypoventilation. So when we're looking at the different causes for respiratory acidosis, we're looking at all the different reasons why a patient might have hypoventilation. So one of them is alveolar capillary diffusion, or ARDS, so decreased capillary diffusion. So that means we know that our alveoli in our lungs are responsible for that gas and blood exchange. And so in ARDS, or any other issue where we're having issues with diffusion, that process is interrupted. And we're going to talk way more about that next week. Pulmonary embolism, they could have a blocked pulmonary artery, so they have decreased circulation. Chronic airflow limitations, which would be like COPD, cystic fibrosis, pulmonary fibrosis. So they have trapped CO2 in their alveoli. Pulmonary alveoli that are inflamed have atelectasis, which is air trapping, or they have thick mucus that's blocking the airways. Decreased chest expansion, so that would be like a circumferential thoracic burn, or eschar, or an abdominal binder. And we'll talk more about that when we get to burn. Airway obstruction would be a foreign body or a tumor. So if we have a lung tumor, it's going to obstruct the airways so the air can't come in and out. And respiratory depression, which would be anesthesia or opioids. Signs and symptoms, hypoventilation, and they will then eventually have hypoxia. So the key thing here is shallow. Someone kind of challenged the rapid, but the key word is shallow respirations. You're going to have possible decreased blood pressure, cyanotic skin, headache. You'll have hyperkalemia. You're going to have dysrhythmias related to the hyperkalemia, drowsiness, dizziness, disorientation, muscle weakness, and that is that. And then what are we going to do about it? So intubation, ventilation is the best treatment for most of these. Oxygen removal of obstruction. So if the obstruction is mucus, we have to remember to suction them. How do we know there's mucus? We listen and we auscultate. Bronchodilators. And another treatment is antibiotics if they have pneumonia. Respiratory alkalosis, you're going to have ABG changes. Your pH is greater than 7.45. Your PaCO2 is less than 35. Etiology is hyperventilation, and this can be caused by fear, fever, and anxiety. Some of your signs and symptoms of respiratory alkalosis could be seizures, deep rapid breathing, hyperventilation, tachycardia, low or normal blood pressure, hypokalemia, numbness and tingling of extremities, lethargy and confusion, lightheadedness, and nausea and vomiting. Therapeutic communication is a good treatment for the fear and anxiety. Antipyretics would be like acetaminophen for fever. Often we could use a brown paper bag. And then anti-anxiety drugs are also used. Metabolic acidosis, you're going to have ABG changes such as pH less than 7.35. Your bicarb is going to be less than 22. And this can be caused by 4 different manners. We have increased hydrogen production, so that would be your DKA, where your fat is turning into ketones. Starvation, fats are also turning into ketones. Lactic acidosis, and this leads to anaerobic metabolism. This happens in septic shock. Decreased hydrogen elimination, which would be renal failure and fluid overload. We have decreased bicarb production, which would be our pancreatic disease, and also renal failure causes this. Or we could have increased bicarb elimination, which would be diarrhea. With metabolic acidosis, our signs and symptoms are headache, decreased blood pressure, hyperkalemia, muscle twitching, warm flushed skin, nausea and vomiting, decreased muscle tone and reflexes, Kussmaul respiration, which goes hand in hand with our DKA. That's a compensatory mechanism. It's basically causing your body to hyperventilate in compensation to your metabolic state. Then we have our treatments. The treatment is eliminate the problems. So with DKA, we're going to give insulin and hydration. Starvation is nutrition and hydration. Anaerobic metabolism will give antibiotics and fluid resuscitation. Renal failure, we're going to do dialysis. Pancreatic disease and renal failure, they're going to treat the cause and do hydration if necessary. In diarrhea, we treat the cause and we hydrate. So there's a common theme of hydration here. Metabolic alkalosis, our ABG changes, our pH is greater than 7.45. Our bicarb is going to be greater than 26. This is caused by increased sodium bicarb intake. So this is like accidental acid overdose or taking too many antacids. And increased hydrogen elimination, and this occurs during diuretic usage. So you have a lot of water loss, vomiting, and NG tube to suction. Metabolic alkalosis, you have restlessness followed by lethargy, dysrhythmias, tachycardia, compensatory hypoventilation, confusion. They may have nausea and vomiting, less so on the diarrhea end here. Tremors, muscle cramps, and tingling of fingers and toes, and hypokalemia. One medication that is used to treat metabolic alkalosis only, it is given in the ICU, and it's an IV drip medication, and it's acetazolamide or Diamox, and it can treat metabolic alkalosis. Another way is to decrease or stop their diuretics, to give antiemetics so vomiting stops, and stop that antacid. We can have important electrolyte changes and acid-base imbalances. The way I have you remember it is hyperkalemia and hypercalcemia occur with acidosis. So an easy way to remember that is you're hyper on acid, and that is a good way to remember it. And you'll have hypokalemia and hypocalcemia in alkalosis. A patient with long-standing diagnosis of generalized anxiety disorder presents to the emergency room. The triage nurse notes upon assessment that the patient is hyperventilating. The triage nurse is aware that hyperventilation is the most common cause of which acid-base imbalance. It is respiratory alkalosis. You are an emergency room nurse caring for a trauma patient. Your patient has the following arterial blood gas results: pH 7.26, PaCO2 28, bicarb is 11. How would you interpret these results? So it is a metabolic acidosis with partial compensation. Your pH is 7.26, and this is an acid. Your PaCO2 is 28, and it is a base. Your bicarb is 11, and it is an acid. So our pH and our bicarb match. So it's a metabolic disturbance. There is partial compensation because the PaCO2 is a base and the bicarb is an acid, and so those are opposite, so they are partially compensating.